everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in healthcare IT. And today, we have a panel of a really interesting guests. We have Dr. Colin Banas. He's chief medical officer at DrFirst, Dr. Paul Grundy, an advisor at Grundy Consulting, and Sarah Richardson, CIO at Tivity Health. Welcome, everyone.
Hey, thanks for having me.
It's a pleasure.
Excited for this conversation. And yeah, I mean, we have so many unique perspectives in this, but before we dive into that, if you can just give us a brief intro. Dr. Banas, you want to start?
Yeah, sure. So Colin Banas, I'm an internal medicine physician and hospitalist. I'm currently the chief medical officer for DrFirst, but in a former life, I was the CMIO for a large academic health system.
Nice. And Dr. Grundy, you want to go next?
Yeah, I'm Paul Grundy. I'm the founding president of the Primary Care Collaborative, which led the medical home movement. Currently advising Grundy Consulting and also chief transformation officer at Innovacer.
Awesome. And last but not least, Sarah, tell us about yourself.
Sure. Good morning. Sarah Richardson. I'm currently the SVP and CIO for Tivity Health. Tivity is most notably known as a silver sneakers brand that serves seniors for wellness and fitness in Medicare Advantage plans.
Awesome. Well, excited to have this discussion today. I mean, we're going to be talking about something that's so important to people. And I think, Dr. Banas, Colin, you have a really unique perspective, having been a hospitalist, then a CMIO at a health system, and now chief medical officer at DrFirst. So could you kick us off, talking about where do we stand today in regards to sharing health information between systems?
Yeah, it's interesting. We're certainly a lot further along than when I first started in my practice. But the fact that there are still fax machines in most clinics and hospitals, and you have to go to the radiology section to get a CD in order to transport your films, it speaks to the fact that there's a long way to go. I will say that a lot of the larger EMRs and health IT companies have made tremendous strides in starting to get the data flowing bidirectionally. But I think we can all agree there's a long way to go still.
Yeah, Sarah, what would you add to that? Where do you see us at? Or is there a story that kind of demonstrates where we're at?
Anyone who has to deal with care of another person and their family, and yourself is just your own ecosystem. But when you have a chronic condition in your family, even for yourself, and you have to manage the medical records, the appointments, the access to care and information, you get a whole new perspective of the things that need to be addressed in any medical environment. And it's not because enough people don't care, John, it's because it's not an easy problem to solve. And so one of the things that I'm always so focused on, really as a leader in both healthcare and technology, is we are all patients. And so if we're also the ones responsible for delivering those solutions who receive the care, then we are the ones that also need to be having those conversations and pushing it forward. So I'd say as the receiver and the influencer, those things coming together every day are a focus point of what I talk to my teams, my peers, and others about in the industry.
Yeah, you make a great point about us all being patients, but I think it's also interesting because as patients, we're kind of beholden to all of these companies and organizations working together, right? I mean, it's about partnership between them. What's been your experience with that, right? I mean, getting companies to work together and share the information. I feel like we've seen a bit of a change in that regard, that people are more interested in sharing with each other. What's been your experience?
So from my point of view, I happen to be a healthcare ambassador for the nation of Denmark, and I guess we're probably about 15 years ahead of the United States. And in that capacity, everybody has a portal with all their health information by law in that portal. They can give that to any physician. It's really cool. And when you see the future now and see it actually working and know it's workable, I just think that's really exciting. But there's three legs of a stool that sort of have to change. One is the cultural shift away from delivering an episode of care, whether you need it or not. The second is the payment change. There's only one way to hurt a cat, and that's to move the food. As long as we're paid to do the wrong thing, we do the wrong thing. And the third is the technology that really allows Colin and his team to have at the point of care exactly what they need for that patient today. And more importantly, have in the system what they need for those patients that are not in front of them that day. And we're making a lot of progress, as Colin and Sarah pointed, but we have a long ways to go. But
Sarah, what were you going to say?
More about the perspective of what Paul shared. It's like, that's what I tell people all the time when we're doing like strategic planning and road mapping and thinking about how do we reduce costs without sacrificing growth and doing all the things that are super important, is that all of the technology is already there. We forget that so often. We keep trying to solve technology with technology, and that's not really what we're up against anymore. It's the ability to elegantly bring the right pieces together at the right time. So if you bring two capable partners together to solve it, they absolutely do. But you often solve those in bubbles because today healthcare is still very much local. I would ask Paul, is how local is healthcare in Denmark, or have they adopted more of that nationwide type of system? And then you get into political fights here. So we started to remove ourselves from all of those aspects and just say, what problem are we looking to solve? The solutions already exist. How do we want to agree to bring them together?
Yeah,
Yep.
I agree. I definitely have seen a culture shift. I think that was your original comment, is that the conversation around interoperability is on a much steeper trajectory than it was, even 5-10 years ago. And in fact, you've seen progress in things like TEFCA announcement and the Sequoia project. And I think, the fact that we're having these conversations speaks volumes. I do think the technology is there. And so I love that three-legged stool analogy in terms of the way we need to get around it. One of the other things that I think we struggle with is the notion of semantic interoperability. So I think we're getting good at pushing, large blobs of data from point A to point B. I still think there's room to go on that too. But then how do we make sure that it maintains its structure or maintains provenance when it lands in its respective system? And so there is a need not only to move the data, but move it meaningfully.
Yeah, could you dive into that a little more, Colin? Because I think that's what's interesting. We all look at interoperability, we're like, we want interoperable data, and sure, we want the right data at the right place. But often that changes the quality of the data if you don't do it the right way. So can you give examples of maybe what's working with Health Exchange and maybe some examples where it didn't work so good, or what does it take to make it, good?
Yeah, it's interesting. So at DrFirst, we specialize in medication management. What started as an e-prescribing company exploded into a myriad of solutions around medication safety and adherence. And despite decades of standardization, e-prescribing and codified structure, data loses its structure along the way in the healthcare journey, because system that's receiving it might not be able to take it in the way it was sent, and so someone has to manually re-enter that data. And the second you introduce human element into it, that's where errors can get introduced. And so, at least in the medication space, which I've really spent a lot of time recently, there is still a lot of free text, a lot of lack of structure, even for things like renewal requests or consuming medication histories for the all-important medication reconciliation. And that's why I think there is an opportunity for tech companies to really insert some innovative solutions into making sure that structure gets preserved or gets recreated in the appropriate format when you're moving data from point A to point B. And so I think that's exciting. And I think that goes back to that question earlier about partnership, in terms of, maybe this company is really great at moving the data and this company is really great at cleaning the data. Let's combine powers and make sure that we're achieving that semantic interoperability that I was referring to.
Paul, go ahead.
I used to think that healthcare was rocket science in terms of data, but I now conclude that it's a lot more complicated than that. I mean, rocket science is relatively easy compared to managing 100 diabetics with 100 personalities and the myriad of medications. I mean, I became the president of the Get the Medication Right Institute because simply put, to Colin's point, the simplest thing we can possibly do if we have a medicine that could actually help somebody is to get that medicine in their mouth or in their arm. And if we can't even do that, it's, and we have somebody die of medication malfeasance probably every 3 minutes in this country. It's really, but about 20 years ago, I really thought that it was going to take an IBM to deliver this kind of change. And so I became the chief medical officer there for years, and with some frustration retired a few years ago. But I'm now seeing some real breakthroughs. The company that I work for, Innovacer, is now best in class, best in Gartner. Some of our competitors are really coming along, but we're beginning to see, I think, for the first time, the sort of right amount of AI put into some of these technologies that begin to make it flush out a bit better. But I'm bullish on our ability to do the technology part and work like heck to try to change payment and to try to restructure the delivery system in a way that it really does focus on health and not an episode of sick care.
Yeah. We're not going to dive into payment today, but I mean, to Colin's point, like there's so much that's free text, right? And how do you gain access to that across it, right? Or, my favorite is when people use different flavors of standards, right? You're like, wait, there's flavors of standards. So is it a standard or is it not? I think it's really challenging. And Sarah, as a former CIO and, even in your current position, you're kind of in charge of that data strategy. What do you see as kind of the role you play, and how can you work through these challenges of being able to share data and then use that data to reduce costs and improve health outcomes?
Yeah, I love the question for myriad reasons. And it starts with the fact that I remember in 2014, I was a CIO at a healthcare system, and we started talking about data governance. And it was a topic that was important, yet not really being dove into very deeply. It was like, oh yeah, we need to agree on what data structures we're going to have. Oh yeah. But you know what? Let's just keep collecting it in these big warehouses of unstructured data, and then we'll get there and we'll figure out how to suss it out later. You find out, let's just fast forward 8 years later, I'm in a different system. That problem exists. I walked into Tivity 11 months ago, and number one, I love this organization. We endeavor to do all the right things for the right reasons. And I'm like, hey, what's our data fabric strategy, or who are we working with on these components? And we're like, oh, well, a couple guys over here that manage our databases. And I was like, well, what's in those databases? What do they look like? And you're like, And if you're data obsessed, like I am with my team, and thinking about the ways that you can use analytics to really get deep insights into your organization, you realize that you have people doing so much manual work, and like that's not sustainable. And so I started automatically. I brought in 2 months after I was there, a vice president of enterprise data services who has a deep background from one of the major EMR vendors. And we went from a team of ideators, so just thinking about, data management's really important. We now have 20 people on that team with a 3-year roadmap that is significantly set in some basic disciplines that are very, very important. You have to have data governance. You have to have a way that brings things in to discover it, to make sure it's high quality, to cleanse it, to own it. So you've got data owners all over the company. That governance structure is really, really important, because before you load it into an Innovacer product or Snowflake or whatever you're using as your enterprise data warehousing, ideally cloud-based, I'll just throw that out there, it has to be clean data before you put it into a new system. Otherwise, you are wasting your time and your money. And we use Innovacer at Optum, and now we use Snowflake here at Tivity. The data foundation, how it feeds omni-channel in your marketing, how you use your business analytics, your reporting, your intelligence on top of that. And then ideally, all of that can be monetized. You've got everywhere from zero to third-party data. And it's not monetization because we're selling your name to somebody to sell you products. We are taking those deep behavioral insights and partnering with major providers of healthcare systems, insurers, to make sure that we can really drive behavior that is based on your intrinsic motivators and needs. All of that starts at that root of saying, oh my gosh, what am I bringing into my system, and how well am I keeping it clean from the get-go? That is a significant investment of time and strategy, and where we always want those quick payoffs. So it has to have an ROI within a year. You're going to get a little bit of that ROI in a year, but by year 3, you have something that fundamentally is an industry standard.
That's great. Colin, anything you'd add to this conversation as far as, driving the outcomes you want, and what does it take? I mean, Sarah talked about a team of 20 now, but that's with hundreds of vendors probably, right? I mean, I think it is those partnerships with those vendors and things to be able to drive the outcomes. It's not, one person on an island.
Yeah, it's interesting because from the clinical perspective, you think about Sarah's team of 20, making sure that the data is clean. From a clinical perspective, when I'm the consumer of that data, wearing my clinician hat, I'm doing a similar exercise, in real time to bring that data in and to make sure that it's clean. Because if I don't, that's how patients get hurt, whether the data is missing or whether the data is incomplete. And so I think, similar conversation on both levels, whether it's at the data warehouse level or at the clinical level, this need to preserve data integrity and cleanliness, for lack of a better word. The other thing that I've noticed, and I think is a tremendous opportunity for AI or for tech companies, is if you are in an organization that is fortunate enough to start having these connections, you're connected to an HIE or you have insight into the other large EMRs in your area, what I've started to notice is actually there's a problem of too much data, and particularly too much duplicate data. And so there is this, I think there's a tremendous opportunity for deduplication or sort of better summarizing or better consolidating data into a consumable and easily readable format for our clinical teams.
Interesting. So what kind of solutions would you propose for that? I mean, is it just being deliberate about it, or is there a technology solution, or what's your thoughts on how to solve that?
Yeah, a little bit of a loaded question because it's one of the things that DrFirst is working on in terms of our medication safety solutions. But yeah, I think we can be very intentional with your algorithms. I don't need to see the azithromycin Z-Pak from 5 years ago when you're, presenting with a potential cardiac arrest. So I think there's ways to filter out unnecessary data. I also think there's ways to be very intentional about consolidating duplicate entries and presenting just, the one data point. Because what happens is you're asking the clinicians to reconcile multiple instances of the same data point. And whether that's time, whether that's clicks, it's all a distraction from the ultimate end game, which is clinical care.
Yeah. Paul, anything you'd add from kind of the patient-centered care? I mean, you're adding a whole swath of new data from the home, right? Which just adds to the complexity of the problem.
So from the point of view that Sarah made about the data, I mean, I always think of that as the source of truth. I mean, you need to have a foundation of information that is a source of truth, and it needs to be as comprehensive as possible across medication claims, social determinants of health information, healthcare information, and pulling that together on a cloud-based platform, and then putting Snowflake or Innovase or one of the solutions that can pull that all together as a single entity and then parse it to the end user in the way that end user can use it best. From the standpoint of the clinician, what they need is the 5 things that they need to do that day, preferably formatted as a huddle so that the entire team is looking at that information and sorting it out rather than just the doc, so that the person who's calling to confirm the appointment the next day can begin to understand what they need to do for that patient. And then it can be parsed to the consumer in a way that as that consumer leaves the doctor's office, they get a text message that says, these are the 4 things you need to follow up on this appointment, right? And 2 days later, a reminder that says the same thing. I mean, that sort of concept of data management. You're going to need data in a different format for the care manager than you are for the hospital. But if you take that platform, that source of truth, I think of 4 quadrants above that. It's the information you need to know about the population, down to the individual level for that case manager, up to performance, how's everybody doing, and finally that last quadrant, cost, which is just immensely important. But those are the 4 elements that you need to build on that data platform that Sarah talked about. And again, I think now that we're doing a lot of this in cloud, and we have, tools like Innovacer and Snowflake, I mean, we can begin to actually get at some of this in a meaningful way. And it's going to make Sarah's life a whole lot easier when you're not being asked to, the Tom Sawyer model, where you're not asked to pay to paint to put the whitewash on the fence, by the EMR vendor, right? I mean, it just breaks my heart when I go into a clinical practice and watch what the clinicians are doing with their time. They're burning out. They're spending 1/3 of their time in the two things a clinician should do: difficult diagnostic dilemmas and relationships. Everything else should be done by somebody else. And the last thing you want to pay a clinician to do is to be a scribe, right? I mean, it's just terrible.
Yeah, well, it's interesting, the two examples you've kind of given and how different they are, but the problem is the same. So Colin talked about, the challenge of medication reconciliation and using technology to just show the data that's relevant, right? Which is a massive data problem in and of itself. Like, I don't need to know about the Z-Pack because you're having a heart attack or whatever it might be, right? That's interesting. And then Paul, you're talking about it more from the kind of, data warehouse perspective, all of the data, not just for the specific use case, but for a population as a whole. But it's interesting how in both cases, whether you're dealing with the population as a whole, or whether you're dealing with an individual patient at the bedside with a doctor, they both have the same problem, which is there's too much data, and which data is relevant to that specific situation. And I mean, that seems like the summary of what we have to do. Sarah, anything you'd add there? I mean, and to me, this feels like the move to value-based reimbursement and value-based care. And the key to it, is that what you see as the data related challenges to this shift to value-based care and, the shifts that are happening in healthcare?
What's been interesting is that I'm obviously always solving for the here and now, and then having the 1 to 3 year roadmaps that are out there. But I also have a lot of conversations with futurists that are looking at what happens even 10 years down the road. And I've recently been able to met a gentleman named Dr. Stephen Charlap. He's a serial entrepreneur. His latest company is called Soap Health.
Okay.
Go figure, because he was a doctor. And he talks about, PCPs make less now than they did 50 years ago, based on the burden of what's expected of them, based on the joy of the job that they have and how they receive things. And they get, back to 15 minutes with patients. And so if you're really looking to be able to create precision patient profiles, there's a component where the doctor will always be at the center of that. Yeah, if you think about information you can get from labs, remote monitoring, genomics, EMR data, and you start creating these ultimate aggregators, those intake engines and those consistent monitoring capabilities of how you absorb some of this data really comes to your ability to use the right AI and the right technologies to be able to say, you know what, your intake with an AI avatar is a 45-minute conversation that's programmed specifically to do that with you. And all the time in the background, all these algorithms are running to be listening for things in some cases that aren't being said. You think about that ambient capability. So I may share, literally, there's research that shows you'll share more with a digital avatar than you will with a human, because you're not embarrassed to tell a computer the truth. And all of those elements start to come together. So when you think of the continuum of care of that patient, when they're not with you, or they're not in a hospital, they're at home, and they get exercise by walking their dog. So what they're really looking for next is the human connection, to have someone socially engage with them in those capabilities. And you can predict and you can offer those next best actions across the board. So many of the pieces that we leave out of the equation is that what I call the whole human, and not just episodically in front of somebody at a given point of time. If we're always solving for that ability, I joked, I'm like, that's who's taking care of me in 30 years, is that avatar, because she's always paying attention to me. When we start to really get to those spaces, you create, again, the precision patient profile. So all your data sources are an ultimate aggregator, and you've taken the guesswork out, and it's really about the application of where the human intervention occurs.
Wow.
And to the point of that profile, I'll tell a story. We one of our clients in Iowa, we began to see a real uptick in hospitalization for our type 2 diabetics. And when we looked at the data, what we began to see was it was happening in a few zip codes, and it was happening at the end of pay periods. I mean, what the docs were doing were fiddling with the insulin level. What was happening to the patient was they were running out of food. And understanding that and seeing the data that documented that, and then hooking them up, in this case, to Aunt Bertha and to food banks, fix that problem, right? I mean, that's another concept of the data, that's, really important to be able to not only mine what's happening, in the clinical environment, but to mine what's happening in that patient's world, that they live in. When 40% of our patients don't have $400 for an emergency, right? I mean, it's that understanding that will really begin to impact, and support actually value-based care.
I mean, these are such forward-thinking perspectives that Sarah and Paul both shared. But I think one of the challenges when I talk to EHR vendors is that their list of things they need to improve is so long, right? And they still have to keep their core of getting the organization paid and all those things. So I think, I don't know, it's just interesting to find the balance between innovation and keeping the lights on. There's a little the challenge there. How do you see it, Colin? And you work with a ton of EHR vendors, right? And I think DrFirst is a great partner with so many of them. How do you look at this data challenge, as a partner to these EHR vendors who, let's be honest, are overwhelmed with the data that's coming in at them from patients, from doctors, from labs, from everywhere? How do you see that from a partner relationship?
I think it's a tremendous opportunity. I think, one of the first things in both of my roles in health IT, whether it was CMIO or CMO now at DrFirst, is understanding from the clinical perspective, what problem are we trying to solve? So, in this case, and again, this is not every health system, but if you are a health system that is fortunate enough to have these connections, and if you don't have these connections, that's when you're still using the fax machine that inevitably we all still have. The data overload problem is one of the things that continues to come up over and over again. It's, so when I started my residency, I remember distinctly breaking in, and I say that loosely, but literally breaking into the file rooms in cardiology to get a look at the echo, or the big rooms in the primary care office to get a look at the progress notes. And of course, as we've digitized, some of those things have gone away and I have more access. But as we've all pointed out, at times it's overwhelming. And so I think there's a tremendous opportunity, as I said before, either in deduplication or in accurate clinical summary, using technology and AI to consolidate and preserve structure. And so I think it's a wonderful time to be a health IT vendor who can partner with other health IT vendors, whether it's core EMRs or whatnot, because we are having these conversations about interoperability and about the problems that we can solve together, rather than just saying, well, the EMR is going to fix that for me. Because I think, 20 years later, we know that that's just not the case.
Yeah.
When I started the primary care collaborative and the patient home movement, the fundamental question I asked was, now that we're going to have data, where's the system integrator? Where does it go? Who's accountable for that data? And a guy named CHCIO, who was the person who first coined the term medical home, was talking about a home for the data. He wasn't talking about a home for the patient or a home for the doctor. If you're going to have data, where does it go? And what Cal understood was that children with special needs, they have a bunch of people working on them. They have teachers, they have psychologists, they have social workers, and if they're not singing from the same sheet of music, the patients didn't do well. I mean, the next group of clinicians that figured that out really quickly were the people who did transplant surgery. Because they need like a whole team of people to approach this. They need immunologists and da. And again, if there wasn't a system integrator, if there was not a place where everybody had the same information, their patients died. And so that core concept, that concept of the source of truth that Sarah talked about, the data, the question I asked was, who's accountable for that? Where is their accountability? And fundamentally, my belief is that accountability works best if there's a relationship of trust between the patient and their healer, right? I mean, and so, that core value system, which is something I've been working on for years, is to try to, to try to understand and develop a relationship of trust with, as the CMO, as the chief medical officer for IBM, we tried to do it for our patients at IBM, et cetera. But, to try to get people into a relationship of trust, but underneath that, to have the information that you needed to have to work on that patient. I got this little note from my cat's veterinarian that said, your cat is due for his immunizations. This was 20 years ago when I started the medical home movement. And I took that little note down to my primary care physician and I asked the question, do you know how many women in your practice are 55 and over and have not had a mammogram?
Mm.
And he said, I have no idea. Patients come in at 9 in the morning and they tell me their problem. I try to do something about it. Again, back to Sarah's point, to Colin's point, you need a registry at least as good as my pediatrician, my vet has, right? For that source of truth to be able to really manage a population with data. So it's not only the data, it's not only cleaning the data and processing the data, but where in the delivery system does that data go? And who's accountable for that data? Where is there accountability in anybody's life? Sarah talked about, managing records with chronic disease. 50% of my patients when I was at IBM couldn't even name a primary care physician, right? They didn't have anybody. And most of those who did have them didn't have anybody that was going to manage them as a population, right? They were going to understand that they should at least notify their patients as rigorously as my cat got notified.
Yeah. Well, it's interesting that we care more about our cat's vet than we do our primary care physician. So there's probably something there. Sarah, as we wrap up, what do you think the impact will be to an organization that doesn't address some of these, data access, data quality challenges that we've talked about?
I smile because when I hear some of these stories, and here I am 22 plus years in healthcare IT and almost 30 years in IT in general, I don't have a PCP because I use Teladoc because it's offered by my company and I don't have anything that's chronic enough or big enough a deal right now. That's terrible because guess what? That record doesn't go anywhere. There's no record of me for like the last 4 years except for the responsible, yes, I go get a physical and those types of things. But so many people really just want a problem solved in the moment and they want the convenience of that. And so there's a big space that says, what do you now do about the digital environment in terms of aggregating some of these records and putting those tools in the patient's hands? But more importantly, data lives everywhere in an organization. It's not just the clinician and that clinical data that's important. It's all of it. It's your finance team, it's your marketing teams, whether it's productivity or compliance or marketing, which I mentioned, they all have a need for that. If you have poor quality or a poor source of truth or no trust in your organization, you get overrun with consultants. Everybody has an idea for how to do it. You end up with shadow IT organizations all over your company, and they're mining their own data from their own sources that they're cleansing, and how accurate is that information? So you end up undermining confidence in organization, you miss key opportunities, you lose revenue, and then those costs continue to spiral, and then your reputation gets damaged. We now live in a world of constant mergers and acquisitions. It will just continue to happen, even in the EMR space. And maybe that number one fallacy is that the EMR is the center of the universe. It is a core component of what we all do in delivering care. So many of the things that are added around that allow you to do the things we've talked about today, and why it's so important that if you don't get in front of it and really pay attention to where everything's happening and a way to create a trusted source of truth wherever you decide that lives in your governance structures, you will literally fall to the competition. And that competition may just be online, and the locality of healthcare then starts to get erased. And that's not something that any of our primary systems are looking to have happen to them.
Beautifully said.
Yeah.
Colin, you want to give us the final word?
I didn't mean to interrupt. Sarah said it so much more eloquently than what I was going to say, which was you're going to get squished if you don't have a data strategy or data governance in place. The margins are so thin as it is, and the competition is everywhere, ready to eat your lunch. But as I said before, Sarah said it much better than I could.
I don't know. I think that you actually highlight it so well that, the data is moving so fast, the volume of data that's being captured is moving so quickly that you're right. If an organization doesn't take charge of it, they will be squished by other competitors. And then to Sarah's point, if we don't manage this data effectively, the message I hear is that we're going to lose the trust of patients. And if we don't have the trust of patients, how can we care for them? So this was an incredible conversation. I appreciate you all for taking part, and thanks everyone for listening. If you want to find more great content like this, be sure to check it out at healthcareittoday.com and search for healthcareittoday.com on your favorite podcasting platforms. Thanks everyone. Appreciate your insights.
Thanks, John.
Only a pleasure.
Thank you.